wait for 5 more minutes to join all the participants. Some more participants are expected to join. So we will wait for 5 more minutes only. Then we will start. Thank you. Good afternoon once again. There are some instruction to join this online orientation program. Kindly keep your mic on mute mode during the session to avoid any kind of disturbances. You can keep your videos on if you want for the better interaction during this session. We are having 3 speakers today. Dr. J.O. Madak, Director, State Institute of Health and Family Welfare, for the opening remarks. Then we'll have orientation of the concept of TAAHO by Professor Dr. Kadri sir. Is professor from BJ Medical College, Ahmedabad, Department of PSM. Then we will have a presentation on the key indicators of TAAHO by Dr. Parag Chavda, Assistant Professor from Department of PSM, GMERS Medical College, Gotri, and one more presentation from SIHFW by Dr. Lipi Shukla, that is Medical Officer at SIHFW, on the indicators. All are requested to keep their mic on mute once again, because there are some instruction to join this, as we will be having large audience during this online program. So to avoid disturbances, please keep your mic on mute mode. We will have question answer session at the end of the program. If you have any, you can note it down during the session, and we will have question answer interaction at the end of the program. Thank you.
with audio.
Good afternoon, everyone. Once again, so we have 200 and almost 20 participants joined, and more people are joining yet. But we will start without waiting much. We are having our director of State Institute of Health and Family Welfare, Dr. J.O. Madhav, with us. Sir will guide us on how this TAAHO program evolved over the period of 1.5 years in the state, and what are different expectations from medical colleges. So we will have an opening remarks from our director, sir. I would request our technical support to share the PowerPoint presentation.
સૌને વંદન. હું ડોક્ટર J.O. માધવ છું, ઇન્ચાર્જ ડાયરેક્ટર સ્ટેટ ઇન્સ્ટિટ્યૂટ ઓફ હેલ્થ એન્ડ ફેમિલી વેલફેર. It is my short introduction. TAAHO, targeted approach to accelerate health outcome, that is mission Niramaya. It started in the previous year, from July 2019. Basically, the idea was to use local resources to accelerate health outcome achievement. That was the idea. The district team had selected 2 talukas or urban ward as per their conveniency and need, and they implemented intensive work of existing resources, utilizing existing resources. That was the idea. That is mission Niramaya. Now, recently, before 2 weeks, in our DRM, that is a meeting headed by Principal Secretary named Dr. Jayanti Ravi ma'am, every Tuesday, she had instructed to implement TAAHO in all healthcare facility. The facility listed and instructed by chair are all medical college hospitals, all district hospitals, that is medical services division, all ESIS division hospitals, all Ayush hospital, uh, in nutshell, all the compartment or division of Department of Health and Medical Services. So this is the first uh, kind of series of first episode to implement TAAHO in all medical college hospitals. The idea is to achieve health outcome, accelerate. Niti Aayog has decided certain area that we all know 7 plus 4, that is 711 indicators. So the facility based implementation at medical college hospital level of all national health program, that is the idea. So I start my short presentation, and then we will discuss for 10-15 minutes if any queries. State has decided the focus area 711 that we all know, multi-pronged strategy to speed up achievement of desired target based on sustainable development goal in Niti Aayog Health Index. These are the area: maternal death, infant death, immunization, nutrition, anemic mothers, low birth weight babies at birth, epidemic mortality, mental health, sex ratio at birth, spacing methods, non-communicable disease. Previously, 5th of every month we had started reviewing maternal services, emergency transfer services. We are meeting on 5th of every month, discussing the issue, coordinating with each other from health and wellness center, sub-center to medical college hospital. We are helping each other. That is the idea of TAAHO. From 5th of next February, we have a conference organizing collaboration with Stanford University and Srimad Ramchandra Mission Dharampur and SIHFW and all our medical colleges. That is for neonatal mortality, perinatal mortality, morbidity. Immunization area, we have a RMTS project. Nutrition, we are starting with anemic mother, low birth weight. Our NFHS 5 indicators of Gujarat are very poor. We are collaborating in epidemic mortality. COVID is a very big success with the help of medical college hospitals. We are collaborating too in mental health area, family planning, like our all medical college hospitals are our capacity building centers for a public health. We are collaborating in non-communicable disease too, health and wellness center, mentoring and capacity building are the example. So we are doing this all things. Recently we had introduced, today itself is a meeting for National Tuberculosis Elimination Program, that is to reduce epidemic mortality. So in nutshell, TAAHO is to accelerate Niti Aayog indicators. That is the idea. Next please. Systematic approach with strategic framework to improve service delivery and thereby reduce burden of disease and out-of-pocket expenditure, and for improving health outcome. 20/6/2019 ના રોજ મીટિંગ થયેલી અહીંયા અને આપણે સૌએ including all our medical college, state program officer, employee management association, CDHOs, RDDs, professor of PSM department, RMOs, THO, medical officer, senior medical officer, all faculty member, and we had decided a framework, training module, everything. Next please. These are some glimpses. Next please. Next please. Background, why TAAHO? We all have much technical knowledge and know-how how to do work. But these are the gap area. Gap area, instance, leadership at facility level, information sharing, information technology. These are the gaps: knowledge, skill, ethics, leadership. We recently, Medical Council of India introduced a competency-based education for medical graduate. This is the idea. We have all everything, but we are missing in certain area like ethics, leadership, etc. So TAAHO is to fill the gap. Next, please. આ ટ્રેનિંગના જે છે એ કોર એરિયા છે. ફેસિલિટી બેઝ મેનેજમેન્ટ માટે આપણે we are practicing doctors, nurses, paramedics too in a medical college hospital. So we have to implement all the national health program. There are 34-35 national health program in a need to be implemented at the facility level from medical college hospital to health and wellness center. These are the core area for training. Information technology no use and use of data, local data. For example, PIP જ્યારે બને છે નેશનલ હેલ્થ મિશન નો ત્યારે મેડિકલ કોલેજ લેવલે શું શું કરવાનું થાય છે, પોતાના સ્ટાફની ટ્રેનિંગ નીડ શું છે, from security guard to chair. Like we are implementing Lux certified facility, so what are the need of what are the training need for that, etc. So information technology, use of data, program implementation is the next thing. Program guideline and implementation at hospital level, and certain soft skill, team building, work in a team, help each other from sub center to medical college hospital, etc. Next, please. મેજર ડોમેન આ છે. આપણે બધા જાણીએ છીએ કે આ ચાર એરિયાની અંદર કોમ્પિટન્સી જરૂરી છે ટુ ડિલિવર better and quality healthcare services at the facility level and also at community level. So we have two separate department for these two separate entities. We have a public health and family welfare division, public health division and family welfare division for community based services, and we have a medical college hospital MA division and MS division for facility based implementation of healthcare for national health program. We are doing that everything. It is a consolidated approach and to change certain behavior and to fill the gaps. So leadership, ethics, knowledge, skill, and use of technology. These are the major domain for training in a TAAHO. Core area છે આ બધા. ઓકે, આ મોડ્યુલ છે જે અંગ્રેજીમાં આપણે જ બધાએ તૈયાર કર્યું છે. ડોક્ટર કાદરી સાહેબ, સ્પેસિફિકલી બક્ષી સાહેબ, એન્ટાયર ટીમ, હેલ્થ અને મેડિકલ કોલેજ અને મેડિકલ સર્વિસીસની એ બધાએ મળી અને ગોત્રીની ટીમે આપણા માટે સ્પેસિફિકલી થોડું મોડિફાઈડ કર્યું છે આપણા જ મિત્રોએ, અને ફેસિલિટી બેઝ આનું ઇમ્પ્લિમેન્ટેશન આપણે કરવાનું છે. આપણો તમામ સ્ટાફ, આપણા ડીન સાહેબથી માંડીને તે અધિક્ષક સાહેબથી માંડીને તે આપણા સિક્યુરિટી ગાર્ડ સુધીના આ ચાર એરિયામાં સેન્સિટાઇઝ થાય અને દર વર્ષે રિફ્રેશરની જરૂર હોય તો રિફ્રેશર મળે, એ રીતની એક વિનંતી છે. કેટલાક 25 કે 26 ઇન્ડિકેટર્સ નક્કી કરવામાં આવ્યા છે અને એ એરિયામાં કમ્યુનિટી લેવલે શું શું કામ કરવાનું છે, કઈ ટીમ કામ કરશે, that all we know. The area are zero maternal death, 50% reduction either. We are doing that. We are meeting on 5th of every month and discussing and designing and changing strategy, doing something. We are progressing to the current PIP target for maternal death is 50. Current year PIP, NHM PIP target. We need to reduce infant death. The target is 50% reduction. 100% of full immunization is the target. Fourth is 100% treatment of severe anemia is the target. Fifth is 100% TB plus HIV screening and treatment. So today itself is a meeting for NTEP, chaired by Honorable Commissioner of Health. Sixth is a 50% reduction in malnutrition. Some children, we are not good in nutrition area as per NFHS 5 data. Seventh indicator is NCD screening as per PIP target. That is current year target is 100%. Malaria elimination as per malaria free Gujarat. This is the slide just to stimulate our mind only. Work done and data reported plus desired. Work done and data not reported, not good thing. Please improve it. Work not done and data reported, that is unethical. Work not done, data not reported, everything is no, not acceptable. This matrix should be implemented at facility level. સહેતુક છે આપણે HMIS નો રિપોર્ટ મોકલવાનો હોય છે અને ઘણા બધા એપ્રોપ્રિએટ ડેટા છે એ હેલ્થ મેનેજમેન્ટ ઇન્ફોર્મેશન સિસ્ટમમાં રિફ્લેક્ટ નથી થતા. We are doing lot of work in all area to સેકન્ડ નંબરના રાઈટ લોઅર કોર્નર જેવી વાત છે. We are doing the work but we are not reporting sometimes. So આ મહત્વની બાબત છે. આ પણ એટલે દરેક લેવલે આ બાબતની જાણકારી બધાને હોય. TAAHOના પ્રોગ્રામની છે. નેક્સ્ટ પ્લીઝ. સર્વે સંતુ નિરામય આ જે ડિઝાઇન કરેલું છે મોડ્યુલ એ અમારા SIHFW ના એક સ્ટુડન્ટની ડિઝાઇન કરેલી છે, કમ્યુનિટી હેલ્થ ઓફિસરના CCCS ના. ફેસિલિટી લેવલે આપણે કઈ રીતે TAAHO ને આ સર્ટેન ઇન્ડિકેટર છે નું ડિટેલ મોડ્યુલ છે એ આપણને આપણા આપેલી મીટિંગ છે ઓરિએન્ટેશન માટેની. જરૂરિયાત મુજબ આગળ મીટિંગ કરતા રહીશું અને આગળ વધારીશું. થેન્ક યુ વેરી મચ.
Thank you very much, sir, for giving overall idea of targeted approach to accelerate health outcomes. Now we are having Professor Dr. Kadri sir from Department of PSM BJMC, and sir is also Executive Director to State Health System Resource Center, Gandhinagar. Sir is with us to give an overview on Niti Aayog Health Index, SDG 3, and the TAAHO indicators, the correlation of all these indicators decided based on Niti Aayog Health Index. Over to you, sir. Unmute नहीं थे सकता है.
Hello. Hello. Good.
Yes, sir.
Good afternoon. Am I audible?
Sir, you are audible. And should we share PowerPoint presentation from this side?
Hello. એટલે હું શેરિંગ કરું છું મારા તરફથી. હેલો.
Okay.
હું મારા તરફથી શેર કરું છું.
Okay.
હેલો. હવે મારી સ્લાઇડ દેખાય છે? હેલો.
Yes, sir.
હા. હેલો. હું મારી સ્લાઇડ દેખાય છે? હેલો. હેલો. હા. હેલો. હું મારી સ્લાઇડ દેખાય છે? હેલો. હેલો. હા. મારી સ્લાઇડ દેખાય છે?
हाँ sir, the slide is visible.
Good, thank you. Thank you. So, good evening, everybody. Almost it is evening. So, just quickly, in the backdrop of the માઢક સાહેબે જે આખી વાત કરી કે એક તાહો પ્રોજેક્ટ છે કયા ફિલોસોફી અને કયા સિદ્ધાંતના આધારે એ કન્સીવ કરવામાં આવ્યો હતો અને હાઉ ઇટ ઇઝ બીઇંગ ઇમ્પ્લિમેન્ટેડ એ વસ્તુની આખી જે વાત છે એની અંદરમાં એઝ અ મેડિકલ કોલેજ આપણે કઈ રીતે હાઉ વી કેન ફિટ ઇન એની ચર્ચા કરવાની છે અને એ ચર્ચા કરતા પહેલા લાર્જ કોન્ટેક્સની અંદરમાં આઈ વિલ ટ્રાય ટુ શેર અબાઉટ ધી કે હેલ્થ પર્સપેક્ટિવ આખું જે છે because largely in the medical college being as a tertiary care institute largely we are focusing on the individual and not as a country as an institute I will be saying so individual to country as an institute एक दृष्टिकोण આપણે ડેવલપ કરીએ અને એઝ અ પાર્ટ ઓફ કન્ટિન્યુ ઓફ કેર હાઉ ધ હેલ્થ ઓફ ધ જે કન્ટ્રીનું વ્યૂ કરવામાં આવે છે અને એની અંદર ઇન્ડિકેટર્સ ડિફરન્ટ હેલ્થ આઉટકમ્સ છે એ કઈ રીતે વ્યૂ કરવામાં આવે છે જેમ તાહોનો છે એ રીતે હેલ્થ ઇન્ડેક્સ છે એસડીજી ઇન્ડેક્સ છે જે વાત કરી ડોક્ટર લીપીએ એ રીતે એનું એક થોડી સમજ કેળવીએ અને એઝ આપણો રોલ એઝ અ કન્ટિન્યુ ઓફ કોર કઈ રીતે હોઈ શકે એની આખી આપણે what will be doing it. So largely health system usually many times આપણે health system ની વાત કરી તો system we always say that we are always all people are converted with the system like GIT system बोलिए respiratory system बोलिए etc. Similarly the health is also system and when we are talking about the health system definitely we all are knowing that system is having anatomy, system is having physiology, system is having the biochemistry. Also we know that the system is also having some pathology and system has to be we have to do identify the pathology and based on and investigate the people and based on the certain investigations જેની અંદરમાં આપણા clinical indicators હોય છે for example TPR જે core indicators છે એ રીતે we are having the indicators for the serological indicators કહીએ કે bloodના other indicators લઈએ છે radiological indicators લઈએ છે why I'm saying that indicators we usually say that reports છે but they are indicators similarly health system છે અને country is one એક આપણો આખો કેસ છે એને ધ્યાનમાં રાખી and we have to view that it has got the health system has got the anatomy, physiology, biochemistry, it has got the pathology also. It has got the certain indicators for the through that investigating that indicators we have to improve the indicator with the overall improving the overall outcome of the patient, similarly outcome of the public health, people's health. WHO and broadly and 6 પિલર ની અંદરમાં 5 પિલર ની અંદર WHO health system ને divide કર્યા છે typically we are always say that system and input છે process છે અને output હોય છે પણ WHO એને 6 બિલ્ડિંગ બ્લોક ની અંદર ડિવાઇડ કર્યા છે જેની અંદર સર્વિસ ડિલિવરી છે whatever the services we are extending it may be preventive it may be promotive it may be curative it may be rehabilitative or palliative the five types of the services in the health system is there. Typically in the medical college we are largely involved into the clinical care and to a certain extent we are involved into the preventive or promotive care and that too in the obstetric and the pediatric cases usually into and rehabilitative care જે હોય છે એ આપણે ઓર્થોપેડિક અને એવી રીતે સિમિલર બ્રાન્ચીસ ની અંદરમાં છૂટા છૂટા કેસીસ ની અંદર થતા હોઈએ છે પણ મેઇન ચંક ઓફ અવર સર્વિસ ડિલિવરી ઇઝ ધી clinical care. But how big this clinical care is the part of the continuum of the care, we can say that because this preventive, promotive, curative, rehabilitative or palliative, these 5 types are actually has to be in the sequence, continuum chain. કઈ રીતે એકબીજાની સાથે જોડાયેલા છે. They can't have the, we can view these all service delivery in isolation. So service delivery important chain and service delivery are 5 components that we have to, when we are talking about the health of the community or the health of the country or health of this district, state or any blocks. And any other health workforce also. Definitely we all are in health workforce. We don't talk about the only doctors. It is entire the health workforce, which many times leader, doctor is the leader many times. Health workforce. So having the health workforce for service delivery is most important. Information is the third important block. So typically clinical case ની અંદરમાં આપણે જોઈએ છીએ તો clinical examination થી we are gathering the information, radiological laboratory investigations we are getting the certain information. Similarly informations also is the third important building block for the health system for the public health or the community. એ રીતે અને એના માટે we are having certain medical drugs છે, products છે, vaccines છે, technologies છે, and of course this all the four things definitely એ પોતે પોતાની રીતે કશું કરી નથી શકતા. A good leadership and the governance mechanism should be there in place. With the good leadership and governance mechanism, these all four things are properly executed. Otherwise, આ ચાર વસ્તુ પડી હોય in isolation માં તો કશું જ થવાનું નથી. So this is the fifth important block છે જે છે leadership and governance છે કરતા. એ ઉપરાંત financing એક additional છે છઠ્ઠું block, એ આપણે આગળ મેં દેખાડી નથી, પણ that is the important. Financing is the sixth important block છે. એ બ્લોકનું properly usage સાથે જો આપણે if we will be delivering the good services which is accessible and have the wide reach to the people. Usually in the hospital, typically what we are seeing that services are people who are coming into the hospital tertiary care centers, એની અંદરનો આપણે સર્વિસીસ આપતા હોઈએ છીએ. પણ when આપણે health system ની વાત કરીએ, system is not only restricted to the four walls of the hospital. It is not a closed institute, but it is an open institute. As an open institute, when we are saying that it is talking with the community surrounded by the catchment areas છે, એ જે ઇન્સ્ટિટ્યૂટ જે જગ્યાએ ઊભી છે બની છે એની આજુબાજુમાં રહેતા લોકો છે એની સાથે એનું લિંકેજીસ હોય છે, અને એ પ્રિવેન્ટિવ, પ્રમોટિવ, ક્યુરેટિવ અને રિહેબિલિટેટિવ સર્વિસીસનું જે આખી વસ્તુ છે એનું કવરેજ ઇન બ્લોક કેવી રીતે થાય છે. અને મેની ટાઈમ્સ પ્રિવેન્ટિવ એન્ડ પ્રમોટિવ સર્વિસીસ આર લાર્જલી મેની ટાઈમ્સ યુ આર એક્સટેન્ડિંગ ઇન ધી આઉટસાઇડ ઓફ ધી હોસ્પિટલ પ્રિમાઇસીસ. તો એનું એક્સેસ અને કવરેજ કેટલું છે, કવરેજ એ પણ બહુ ઇમ્પોર્ટન્ટ રાખે છે. બિસાઇડ્સ દેટ quality of that care and safety, ultimately this all lead to the improved health outcome, and any સાથે સાથે other વસ્તુ parameters પણ improve થતા હોય છે. So this we have to understand as a part of health system. We are talking about the part of health system, so we to understand where we are, how we are placed and where we are placed in the entire milieu of the health system. એની અંદર આ આખી જે વસ્તુ જે health system block ની વાત કરીએ, network, how the network has been actually there in the entire system. Because we are just when we are saying that we are talking about the mainly here sitting over here as a tertiary, but we are not as a tip of the iceberg. We are not there. We are part of the entire pyramid. That we have to understand. And this entire pyramid, when they work in tandem with each other. So a આખું કવરેજ જે આગળ વાત કરી હેલ્થ સિસ્ટમ કવરેજ, એ રીતે એક યુનિવર્સલ હેલ્થ કવરેજ થઈ શકે. કારણ કે વી આર પ્રોવાઇડિંગ સર્વિસ ડિલિવરી ઇમ્પોર્ટન્ટ કમ્પોનન્ટ છે, આટલા જ લોકોને પ્રોવાઈડ કરી રહ્યા છે. બટ હાઉ વી કેન હેવ ધ એક્સટેન્ડ ધી સર્વિસીસ જે આખું બધા સુધી પહોંચી શકે આ આખા બ્લોકની અંદરમાં, વિચ મે બી સેકન્ડરી, વિચ મે બી ટ્રાઇબ ઓફ ધ પ્રાઇમરી. બરાબર, એ આખી જે નીડ છે એને કઈ રીતે we can reach it, એ વિચારવાનું છે. So when you are viewing the entire health system as a part of coverage, you have to see, yes, standing over here, but you are also related with this entire types of the service delivery જે છે health system network છે એનું સાથે જોડાયેલા છે. Broadly ગુજરાતની અંદરમાં જો આપણે વાત કરીએ આખી, so how the health network of the Gujarat is there. We can see that Gujarat, we are having in the government setup, we are not talking about the private hospitals, etc. But in government setup, we are having 3 super specialty hospitals and 3 specialized types of the hospitals. So we are having at the tertiary care level, these 6 hospitals are there. We are having the tertiary care hospital, 29 medical colleges, which now going to be increased. Dental colleges, physiotherapy colleges, nursing colleges, then district hospitals, sub-district hospitals, CSC. Largely when we are talking about this uplifting educations and tertiary care સાથે link છે. But when we are going down, we are seeing that there are the secondary care district hospitals, sub-district hospitals are there also. And CSC to certain extent, urban માં છે અને rural અંદરમાં છે. Then here comes the PSC, primary health centers, આ level પર primary health level પર, which is also having the good mix of the curative care at the same time preventive promotive care, and it extends to the sub centers. એ આખી વસ્તુ આપણે જે નેટવર્ક છે એ સમજવાની જરૂર છે. અને એના કાઉન્ટર પાર્ટી સાથે આપણે જોઈએ છે, besides that some specialized units, આખી institutes ની વાત કરી, talked about how the health network જે આપણે it is there. You may be working over here, but you are the part of the entire milia. This આખા environment ની અંદરના you are the part of it. That we have to understand. So, and Gujarat ની અંદરમાં કઈ રીતે how બરાબર ને what where we are placed and how we are connected with these different institutes એ જોવાની જરૂર. ટર્સરી ની અંદરમાં પીએમજે અને માં જે છે માં વાત્સલ્ય છે બાલ સખા છે એવી અલગ સ્પેશિયલાઇઝ સાથે પણ we are having the service delivery and many more than 5,000 and impaneled છે આની અંદરમાં doctors and hospitals છે. એ રીતે we are having around 147 blood banks. First referral unit mainly for the maternal care માટે specialized છે, emergency obstetric care માટેની છે. એ રીતે specialized newborn care unit નું આખું છે એ યુનિટ છે. NBSC newborn stabilization unit, nutrition rehabilitation center, child in the malnutrition treatment center છે. RBSK ના mobile units છે, which is the રાષ્ટ્રીય બાલ સ્વાસ્થ્ય કાર્યક્રમ, which is having extending large huge એ જે છે ચંક છે અને એ આખું સ્ક્રીનિંગ અર્લી બાળકોની સ્ક્રીનિંગ અને એની ટ્રીટમેન્ટની વાત કરે છે. ડિસ્ટ્રિક્ટ અર્લી ઇન્ટરવેન્શન સેન્ટર્સ 20 જેટલા છે કરતા ઓવરઓલ. અને પ્રાઇમરી હેલ્થ સેન્ટર્સની અંદરમાં ટોટલ આપણે વી આર હેવિંગ ધ અરાઉન્ડ 931 સબ સેન્ટર્સ પીએસસીસ જે છે આટલી જે પીએસસીસ છે આપણે 18,000 જેટલી એ બધા પીએસસી ની અંદરમાંથી અત્યારે વી આર હેવિંગ ધ 4,852 health and wellness centers where we are specialized community health officers we have put, which are mix of again the curative care and the preventive promotive care stuff. So how the network of the entire state is there. It just any understanding happening. I tried to give some understanding about. Similarly, roughly જો આપણે જોવા જઈએ તો where vis-a-vis India and the Tamil Nadu and Kerala where we are standing. આ જે છે જે લેબોરેટરી પેથોલોજી રિપોર્ટ કાર્ડ છે એ રીતે જોઈએ આ રીતે જ આપણે એમ જોવાનું જોઈએ તો કે this is the report card of the community health and the population ની આપણે વાત કરીએ છીએ જેમ કે પેશન્ટ નો વેટ આટલો છે, પેશન્ટ ની હાઈટ આટલી છે, એમ we are saying that patient's population is this much, બરાબર ને. અને એની અંદર બર્થ રેટ આટલો છે, ડેથ રેટ આટલો છે, સેક્સ રેશિયો કેટલો છે કરતા where we are standing. So we can see that એની અંદરમાં we can see that કે how we are આપણો બર્થ રેટ ઇન્ડિયાની સરખામણીમાં where we are in comparison to some good performing states like Kerala and Tamil Nadu. Similarly the sex ratio માં આપણે ક્યાં છીએ જે એ રીતે ડિફરન્ટ એસડીજી ઇન્ડિકેટર્સ ના ટાર્ગેટ પ્રમાણે છે તો સ્ટેટ ટાર્ગેટ 50 રાખ્યું છે. મેટરનલ મોર્ટાલિટી રેટ્સ કહીએ છે એ 75 છે અને કેરલામાં 43 જેવું છે. એ રીતે ન્યુનેટલ મોર્ટાલિટી રેટ વી આર હેવિંગ ધ સ્ટીલ 19 બટ આપણા કરતા almost 25% જેટલું છે એ કેરલા અને તમિલનાડુમાં. So similarly, different indicators are there. Just I'm not going into detail, but giving a glimpse idea about, because these are the indicators or the reports card to know the health status of the community. And when we are dealing as a health professor તરીકે આપણે કામ કરતા હોઈએ તો we have to also see beyond આ વસ્તુને પણ આપણે because certain responsibility is a part of the health system and we are working in the health system. આપણી answerability and આની સાથે રિલેશનશિપ પણ આ ઇન્ડિકેટર સાથે છે. Some way we are contributing, some way other way as a part of entire team who is extending the curative care. એ રીતે ડિફરન્ટ ડિઝીઝીસ ની આખું છે જે ગુજરાતની અંદરમાં માનો 2.4 જેટલા લાખ ડિઝીઝ હોય છે અને 1 લાખે આપણે 232 ડિઝીઝ ટીબી ને નોટિફાઈડ થાય છે. કેરલામાં 75 છે, ઇન્ડિયાની અંદર 177 જેટલા છે. એ રીતે ડિફરન્ટ ઇન્ડિકેટર્સ છે. ન્યુટ્રિશનની અંદરમાં ડેફિનેટલી વી આર compared to that we are not well nourished society, particularly when we are talking about the child. Diabetes નો prevalence rate પણ ઘણું વધારે છે. ઇન્ડિયાની સરખામણીમાં આપણે જોવા જઈએ તો અમુક વસ્તુ સારી છે, અમુકમાં ઓછી છે કરતા, but overall it gives an glimpses that we are having the now cancer ના કેસીસ વધતા જાય છે. And in accidents and injuries now it has become one of the important contributors of the public health problems. Previously when in the 1916 ની અંદર વાત કરીએ 1990 ની વાત કરીએ one of the disability adjusted life years નો સર્વે કરવામાં આવ્યો તેની અંદરમાં કહેવામાં આવતું જોવામાં આવ્યું તો 1990 ની અંદરમાં largely 60% of the disability the contributions of the suffering was largely linked with the maternal health, child health છે, nutrition છે, nutrition related સાથે infectious disease સાથે હતા. But when we are comparing with 2016 તો એની અંદર આપણે જોવામાં આવ્યું 2016 the ratio has reversed. Risk was reversed in terms of that now 60% of the disability or suffering was contributed to the people by the non-communicable disease. Previously it was 30%. And injuries and the accidents injuries no proportions જે 3% જેટલું હતું એ 7 થી 8-9% સુધી વધવા લાગ્યું હતું. So how the profile of the disease of the community is changing, and based on that we have to adjust our health system. That we have to understand. So એના માટેના different norms છે, અને norms પ્રમાણે how health ડિફરન્ટ આપણી પર 1000 પોપ્યુલેશન કેટલા બેડ હોવા જોઈએ, કેટલા પેરામેડિકલ સ્ટાફ હોવા જોઈએ, ડોક્ટર્સ હોવા જોઈએ, અને ગવર્મેન્ટના કેટલી ઇન્સ્ટિટ્યૂટ્સ હોવી જોઈએ. એ રીતે ધેટ વે વી આર સેટિંગ સમ ટાર્ગેટ એન્ડ વી આર એન્શ્યોરિંગ ધેટ કે આવા હેલ્થ રિસોર્સ પર્સન્સ હ્યુમન રિસોર્સ પર્સન જે છે એ અવેલેબલ હોય થ્રુ આઉટ ધી કન્ટ્રી એઝ અ પોપ્યુલેશન નોર્મ, નોટ એઝ એ હોસ્પિટલની અંદરના બેડ્સ અને વોર્ડ્સના નોર્મ પ્રમાણે. એ પણ એક આમાં જોવાનું હોય છે. અને એને સર્ટેન having certain weaknesses and strength ગુજરાતની અંદરમાં જ્યારે વાત કરીએ છીએ, because we are having a good political commitment, good workforce, committed workforce which includes your entire team, extensive network of health infrastructure as I have just shown earlier, then good coverage of health insurance schemes છે એ રીતે કરતા. બટ જે આપણું જે સૌથી weaknesses છે એ skewed distribution of healthcare infrastructure છે, non availability and high attrition of the specialist છે. PSC and CSC નો functioning બહુ ઓછું છે. Largely people are more of the ગવર્મેન્ટ ઓરિએન્ટેડ પ્રાઇવેટ ઓરિએન્ટેડ ફંક્શન્સ પર વધારે કરતા હોય છે. એમનો મોર પ્રાઇવેટ સેટઅપ દેન ધી ગવર્મેન્ટ સેટઅપ. સુપર સ્પેશિયાલિટી હોસ્પિટલનો નેટવર્ક પણ પુઅર છે. એ રીતે પબ્લિક હેલ્થ ફેસિલિટીઝ રેફરન્સ પુઅર છે, જે આગળ મેં વાત કરી એ રીતે. ઇન્ફોર્મેશન જે ફ્લો છે જે એ આપણી પાસે પ્રોપર આવતું નથી, અને એનામાં આઈટી યુટિલાઇઝેશન બહુ ઓછું હોય છે. And now IT has the big boon in increasing the effectiveness, particularly health system जो मोटी होय. We all are knowing that कि WhatsApp थी even अपने clinical care ની અંદરમાં પણ WhatsApp is helping a lot. Patient X-ray પણ મોકલાઈ દેતો હોય છે, and we can just see the X-ray અથવા તો એનો CT scan નો કે MRI નો જે વિડિયો આપણી પાસે આવી જાય છે. So this is the very crude utilization of the IT, but it's a very systematic utilization of IT is there. અને એના આધારે પણ આપણે હેલ્થ સિસ્ટમની ઇફેક્ટિવનેસ અને આપણી હેલ્થ કેર ડિલિવરીની ઇફેક્ટિવનેસ વધારી શકીએ છીએ, પણ એ અનટેપ્ડ રહી ગયું છે. એ રીતે certain opportunities are there. Definitely we are having the good IT infrastructure, wide cellular network, good road connectivity, good network of private health sector, high literacy rate in the states છે. એ રીતે પણ એની સામે અનકન્ટ્રોલ્ડ અર્બનાઇઝેશન છે, ઇન્ફેન્ટ મોર્ટાલિટી રેટ ઘણી હાઈ છે, એની સામે ડેન્સિટીઝ વધતી જાય છે. આપણી સામે ન્યુટ્રિશનના પ્રોબ્લેમ છે જ કરતા માઇગ્રેટ પોપ્યુલેશન છે વધારે છે. એન્ડ ડે બાય ડે ઇનફેક્ટ વી આર ફાઇન્ડિંગ દેટ બિહેવિયર રિસ્ક, બીકોઝ ઇટ ઇઝ સેડ દેટ ધ હેલ્થમાં તમારું જે સોશિયલ ડિટર્મિનન્સ 40% કન્ટ્રીબ્યુટ કરતું હોય છે, અને આપણું બિહેવિયર જે છે અરાઉન્ડ 20% કન્ટ્રીબ્યુટ કરતું હોય છે. ક્લિનિકલ કેર તો 10% જ ખરેખર કન્ટ્રીબ્યુટ કરતું હોય ફોર ધ ઓવરઓલ અવર હેલ્થ આઉટકમ્સ. આઈ એમ નોટ સેઇંગ અબાઉટ ગેટિંગ ક્યોર્ડ. ક્યોર કરવા માટે ડેફિનેટલી ક્યુરેટિવ સૌથી ડિઝીઝ વ્યક્તિ માટે, પણ ઓવરઓલ હેલ્થ આઉટકમ્સ માટે, ફોર એ ગુડ હેલ્થ માટે, ધીસ ઓલ અધર ડિટર્મિનન્ટ્સ આર ઇમ્પોર્ટન્ટ. અને બિહેવિયર રિસ્ક ફેક્ટર્સ વધતું જાય છે. એન્ડ નાઉ એર પોલ્યુશન. At point of a time, we are having the contaminated water as a problem, and because of that, we are witnessing large number of the diarrheal cases. But now we are seeing that because of the air pollution, lakhs of the people are dying, early dying. It is indirectly contributing, in certain extent directly contributing, but air pollution has now become the important public health risk factors. આ બધાને ધ્યાનમાં રાખીને to know the status of the how the community health status શું છે, તો નીતિ આયોગ એક કમ્પોઝિટ ઇન્ડેક્સ બનાવ્યો છે, અને અત્યાર સુધી એને 2 રિપોર્ટ્સ મોકલ્યા છે કરતા. અને એ ઇન્ડિકેટર્સમાં ઇટ ઇઝ ધ કમ્પોઝિટ ઇન્ડેક્સ. બેઝડ ઓન કમ્પોઝિટ ઇન્ડેક્સ વોટ ઇઝ ધ હેલ્થ સ્ટેટસ ઓફ ધી સ્ટેટ. ગુજરાતનો હેલ્થ સ્ટેટસ ઓવરઓલ કેવો છે, પાછલા વખતથી અત્યારે એનું ઇમ્પ્રુવમેન્ટ કેટલું થયું છે, એનું એક કમ્પોઝિટ ઇન્ડેક્સ બનાવ્યું છે એની અંદરમાં. અને એની અને વિસાવી બીજા સ્ટેટ વિસાવીઝ હાઉ વી આર સ્ટેન્ડિંગ, એ કમ્પેરિઝન કરવા માટેનું આ એક ઇન્ડેક્સ છે. વાય આઈ એમ જસ્ટ શેરિંગ અબાઉટ ધીસ ઇન્ડેક્સ, બીકોઝ ધ કોમ્યુનિટી હેલ્થની વસ્તુ when we are talking about the monitoring the health of the people community, ત્યારે આવા ઇન્ડિકેટર્સ બહુ મહત્વના થઈ જાય છે. અને એની અંદરમાં એક મિકેનિઝમ હોય છે કમ્પોઝિટિંગ, ડિફરન્ટ સ્કોર્સ આપીને એનું આ કરતા હોય છે, જે આપણે તાહોની અંદરમાં પણ કરી રહ્યા છે. So when we are doing, we have also developed the indicators for the TAAHO. એ રીતે આની અંદર ટોટલ નીતિ આયોગે 28 ઇન્ડિકેટર્સ રાખ્યા છે, જેમાં હેલ્થ આઉટકમ્સ છે, પ્રોસેસ ઇન્ડિકેટર્સ છે, અને અમુક ગવર્નન્સ એન્ડ ઇન્ફોર્મેશન્સના ઇન્ડિકેટર્સ છે. just quickly go through it કે કેટલા દરેકના કી ઇન્ડિકેટર્સ કયા કયા રાખ્યા છે. આઈ એમ નોટ ગોઈંગ ટુ explain it, but how, which are the indicators largely we are focusing? Key health indicators of maternal mortality rate, new mortality rate, under 5 mortality rate, stillbirth rate, sex ratio is at birth, TFR, LBW, એ રીતે છે. એ રીતે ઇન્ટરમીડિયેટ હાથમાં ઇમ્યુનાઇઝેશન છે, ઇન્સ્ટિટ્યુશનલ ડિલિવરી, એનેમિક મધર, ટીબી, HIV, આઉટ ઓફ પોકેટ એક્સપેન્ડિચર શું છે, એ રીતે છે. ગવર્નન્સ ઇન્ફોર્મેશન્સની અંદરમાં રિપોર્ટિંગ ક્વોલિટી કેવી છે, જે હમણાં માડક સાહેબે આખી વાત કરી કે ડેટા આવતા હોય છે પણ એથિકલ ડેટા છે કે કરેક્ટ ડેટા છે, એ બે ઘણા બધા ઇસ્યુઝ હોય છે. ક્વોલિટી અને એથિક્સ ઓફ ધ ઇન્ફોર્મેશન આર ધેર. તો એ એની ઇન્ટિગ્રિટીની વાત છે, એના ગવર્નન્સ સ્ટ્રક્ચર શું છે, HR કેટલું છે, ઇન્ફ્રાસ્ટ્રક્ચર શું છે, એ બધાના જે ટોટલ ઇન્ડિકેટર્સનું આખું સ્કોરિંગ કરી અને એનું ઓવરઓલ શું આવે છે એની વાત કરવામાં આવે છે. આઈ એમ નોટ ગોઈંગ ઇન્ટુ ડિટેલ અબાઉટ ઇટ, બટ ધીસ ઇઝ ગિવિંગ ઓવરઓલ આઈડિયા અબાઉટ. અને બેઝ ઓન ધેટ એક હાઉ જે લાસ્ટ હેલ્થ ઇન્ડિકેટર્સ હતા એનું એ લોકોએ રેટિંગ કર્યું હતું. તો એની અંદરમાં રેટિંગ કરવામાં આવ્યું હતું. દર વર્ષે કરતા હોય છે. આ વર્ષનો પાછલા વર્ષનો રિપોર્ટ ડિલેટ થયો છે 2019 નો, પણ ધેટ ઇઝ ઓલ્સો ગોઈંગ ટુ કમ. પણ એના પહેલા 17 અને 18 નો કરવામાં આવ્યું હતું. 18 નો જે રિપોર્ટ હતા એની અંદરમાં એસ્પિરન્ટ્સ એટલે જે હતા એ લોકો aspirants એટલે poor performing actually, but they're using the word aspirants because we have to aspire for improving these things. તો એસ્પિરન્ટ્સ જે પાછલા વર્ષે જે એસ્પિરન્ટ્સ હતા એની અંદરમાં ઇમ્પ્રુવમેન્ટનું કેટલું હતું, તો એમાં જોઈએ કે મધ્યપ્રદેશ, ઓડિશા ને એ પાછળ જ રહ્યા હતા. 0 or less પાછલા વર્ષની એમની સરખામણીમાં ઓછા હતા, અને રાજસ્થાન એની સામે મોસ્ટ ઇમ્પ્રુવડ હતું જે એના એક વર્ષની સરખામણીમાં. એ રીતે એચીવર્સની અંદર જે હતા એ એચીવર્સની અંદરમાં સ્ટેગ્નેશન રહી ગયું હતું. વેસ્ટ બેંગલ, છત્તીસગઢમાં પણ, હરિયાણા, ઝારખંડ અને આસામ વધારે સારા હતા. ગુજરાતમાં વી આર ધ લીસ્ટ ઇમ્પ્રુવડ, ધો વી આર ધ ફ્રન્ટ રનર. આપણે રેન્ક સારો હતો, આગળ હતા, બટ વેન સબસિક્વન્ટ ઇમ્પ્રુવમેન્ટની વાત કરીએ છીએ તો એની અંદરમાં વી આર લીસ્ટ ઇમ્પ્રુવડ હતા. તો સિમિલરલી વિસાવીસ પાછલા વર્ષની વિસાવીસ આપણે ક્યાં ગયા, હાઉ વી આર ઇમ્પ્રુવિંગ ધ હેલ્થ ઓફ ધ પીપલ, એનું આ કમ્પોઝિટ ઇન્ડેક્સથી જોવામાં આવે છે. અને એનું એક મેટ્રિક્સ બનાવીને રિપોર્ટ કાર્ડ દરેકને ઓવરઓલ પરફોર્મન્સના આધારે આપવામાં આવે છે બેઝડ ઓન ઇન્ક્રીમેન્ટલ પરફોર્મન્સ. એને આ જે ઇન્ડિકેટર્સ છે એને આપણે જે ઇમ્પ્લિમેન્ટેશનમાં કમ્પોઝિટ ઇન્ડેક્સને ધ્યાનમાં રાખવામાં આવે છે. તો નીતિ આયોગના 7/11 ઇન્ડિકેટર્સ ગવર્મેન્ટ ઓફ ગુજરાતે આઈડેન્ટિફાઈડ કર્યા છે, એન્ડ ધે આર લાર્જલી ફોકસિંગ ઓન ઇટ. And many of the TAAHO ni andar you will be seeing that many of the indicators are from these indicators like maternal health, infant health, immunization, nutrition, anemic mothers, low birth weight, babies at birth, epidemic mortality, mental health, sex ratio at birth, spacing methods, and non-communicable diseases. So 7 are the core focus areas, and these 4 are the additional, that is the maternal mental health, sex ratio, space methods, spacing methods, and NCDs, which is the emerging. So this is the 7/11 indicators. TAAHO આગળ માડક સાહેબે આખી વાત કરી છે, so I am not going into the detail about it, but basically the very much concept is that targeted જે આપણે achieve કરવાના છે accelerated by intervention ની સાથે આપણે health outcome ને accelerated કરવાના છે. મેઇન એ ફિલોસોફી છે. એટલે કે based on these health indicators we are identifying the blocks which are poorly performing, and ત્યાં આપણે ટાર્ગેટેડ ઇન્ટરવેન્શન લાઈક લેસર થી કેવી જે સર્જરી આપણે કરતા હોઈએ છીએ કે જે સ્પોટ છે કે અહીંયા લોકલ સ્પોટ છે એની ઉપર આપણે ટાર્ગેટેડ ઇન્ટરવેન્શન્સ એટલે માનો લોકલ એન્ટીબાયોટિક્સ આપતા હોઈએ, કીમોથેરાપી આપતા હોય ફોર એક્ઝામ્પલ. સર્ટેન આર જનરલાઇઝ અને સર્ટેન આર લોકલાઇઝ. તો લોકલ છે તો લોકલ સ્પોટને આઈડેન્ટિફાઈડ કરીને ત્યાં આપણું ઇન્ટેન્સિવ ઇન્ટરવેન્શન્સ કરવા જોઈએ જે એની અંદરનો, જેથી એનું આઉટકમ્સ વી કેન હેવ ધ બેટર આઉટકમ, ઇમ્પ્રુવડ આઉટકમ. તો મેઇન કમ્પોનન્ટને આખરની આખી જે વાત કરી છે એટલે હું એમાં જતો નથી, પણ લાર્જલી આઈ એમ ટોકિંગ ધેટ કે ધીસ ઇઝ ધ ઓલ અબાઉટ ધ કમ્યુનિટી હેલ્થ નેટવર્ક્સ, એન્ડ ઓલ્સો ધીસ વી આર ટોકિંગ અબાઉટ ધ વોટ ઇઝ ધ TAAHO અને એની સાથે ઇન્ડિકેટર્સનું કઈ રીતે છે. Now it comes that what is our role as a healthcare providers in or the experts in working in the tertiary care hospitals, any other medical colleges, and also role check. So largely apno 6 role we can see that how we can be the part of, because જે આગળની મેં કન્ટિન્યુ ઓફ ધ કેરનો એક પિરામિડ દેખાડ્યો હતો ને, તો ધો વી આર સિટિંગ એઝ અ ટીપ ઓફ ધ એનું પિરામિડના ટીપ પર બેઠા છીએ, પણ વી આર નોટ ઇન આઇસોલેશન, વી આર ધ પાર્ટ ઓફ ધીસ એન્ટાયર હેલ્થ સિસ્ટમ નેટવર્ક. એન્ડ એ હેલ્થ સિસ્ટમ નેટવર્કની અંદરમાં આપણે જે બોટમની અંદરમાં જે રહેલી છે એની સાથે લિંક થયેલા છે. તો એ લિંક થયેલા જે છે એ લિંક સિસ્ટમને હાઉ વી કેન contribute as a team, not as an individual, સો દેટ અલ્ટિમેટલી આખી કોમ્યુનિટીના હેલ્થ ઇન્ડિકેટર્સ જે છે, હેલ્થ સ્ટેટસ છે, એ ઇમ્પ્રુવ થઈ શકે. અને એની અંદરમાં બિંગ અને ગવર્મેન્ટ સિસ્ટમની અંદરમાં કામ કરતા ત્યારે આપણો રૂલ લાર્જલી વધી જાય છે. તો એમાં હાઉ વી કેન કન્ટ્રીબ્યુટ. એક તો આપણું છે ઇન્ફોર્મેશન હબ છે, વી આર ધી નોલેજ જે છે એના એક એપેક્સ ઇન્સ્ટિટ્યૂટ તરીકે છીએ. તો ડેફિનેટલી વી કેન હેવ ધ 3 ઇમ્પોર્ટન્ટ એની અંદર રોલ થઈ શકે છે. જે હેલ્થ ઇન્ડિકેટર્સ છે, હેલ્થ પ્રોગ્રામ્સ છે, જેની અંદર પ્રિવેન્ટિવ, પ્રમોટિવ, ક્યુરેટિવ કેર્સ છે, એની અંદરમાં જે નીચે ફિલ્ડની અંદરમાં આખું જે વર્કફોર્સ થયું છે હેલ્થ એક્સપર્ટ્સના ડિફરન્ટ લેવલમાં, બોટમ ટુ સેકન્ડરી કેર સુધીની જે લોકો બેઠા છે, એ બધામાં આપણે વી કેન એક્ટ એઝ એ મેન્ટર તરીકે, એમને મેન્ટર થઈ શકે છે, એમના ટ્રેનર તરીકે થઈ શકે છે. ટ્રેનર અને મેન્ટર આઈ જસ્ટ સેપરેટલી મેન્શન ઇટ, કારણ કે ટ્રેનર ટ્રેનિંગ આપવાનું છે, પણ મેન્ટર જે છે એ હેન્ડ હોલ્ડિંગ કરવાનું છે. ટ્રેનિંગ મેની ટાઈમ્સ વન ટાઈમ જોબ and mentoring is the extension of the training. એવું છે કે જે હેન્ડ હોલ્ડિંગ કરીને કન્ટિન્યુઅસ સાથે જે આપણી સાથે કેચમેન્ટ એરિયાની અંદરમાં આપણી સાથે લિંક જે હેલ્થ નેટવર્ક ઇન્સ્ટિટ્યૂટ છે એને જોડાયેલા વર્કફોર્સને એની એ ઇન્સ્ટિટ્યૂટ્સને હાઉ વી કેન એક્ટ એઝ અ મેન્ટર, એ આખો એક આપણો રોલ આપણે વિચારી શકીએ છીએ એની અંદરમાં એઝ અ રિસર્ચર. કારણ કે ઇમ્પ્લિમેન્ટિંગ પ્રોબ્લેમ્સ હોય છે, ડિફરન્ટ હેલ્થ સર્વિસ ડિલિવરીઝના મેડિકલ ઇસ્યુઝના પ્રોબ્લેમ હોય છે. એઝ એ રિસર્ચર લોકલ હેલ્થ પ્રોબ્લેમ્સ કયા છે, એ હેલ્થ પ્રોબ્લેમ્સ માટેના ફેક્ટર્સ કયા છે, બરાબર, લોકોના બિહેવિયર કઈ રીતે એમાં અસર કરી રહ્યા છે, હાઉ ધ ડિઝીઝ આર ટ્રાન્સમિટેડ, હાઉ ડિઝીઝ આર અકરિંગ, બરાબર ને, વેર ધ વિચ ગ્રુપ ઓફ ધ પીપલ આર લાર્જલી અફેક્ટેડ, વિચ એરિયા ઇઝ લાર્જલી અફેક્ટેડ, કયા ગ્રુપની અંદર વધારે ડેથ થાય છે, કયા ગ્રુપની અંદર વધારે ડિઝીઝ થાય છે, બરાબર, કયા ફેક્ટર્સ વાળા. સો મેની ઓફ ધીસ એ વસ્તુ જે છે એ આપણે એઝ અ રિસર્ચર પાસે આવતા સેકન્ડરી ડેટા, જે પેશન્ટ આવતા હોય છે એના જે સેકન્ડરી ડેટામાંથી આપણે એની પેટર્ન્સ છે એને થોડું મોર મેથોલોજીકલ એનાલિસિસ કરીને આપણે કહી શકીએ છીએ, અથવા બેઝ ઓન ધેટ એક્સપિરિયન્સીસ જે ઓબ્ઝર્વેશન્સ આવ્યા છે એના આધારે એક સારી સ્ટડી ડિઝાઇન કરી અને એક લોકલ હેલ્થ પ્રોફાઇલિંગ ની સાથે સાથે હેલ્થ માટેના જે પાછળના ફેક્ટર્સ છે એને પણ આપણે આઈડેન્ટિફાઈડ કરી શકીએ છીએ. અને ધેટ વી કેન વિથ ધી ઓવરઓલ હેલ્થ સિસ્ટમ છે જેનો રોલ હોય સેકન્ડરી કેર વાળાનો, પ્રિવેન્ટિવ પ્રમોટિવ કેર વાળાનો, એ લોકો એના આધારે એનું એક્શન્સ લઈ શકે છે. એનું એક સીધું એક્ઝામ્પલ આપું છું. ગુજરાતની અંદર છેલ્લા 2 વખતથી મેડિકલ કોલેજમાં જે મેટરનલ ડેથ થઈ રહી છે, તો આ સોમવારે ડોક્ટર કમલ ગોસ્વામી સાહેબ જે હતા પીડીયુના, એમને મેટરનલ ડેથ માટેના જે કેસીસ આવ્યા હતા એમને ત્યાંનું એનું એક બહુ સારું એનાલિસિસ કરીને પ્રેઝન્ટેશન કર્યું હતું. એના પહેલા ગોખલે સાહેબ એસએસજી ની અંદરમાં મેટરનલમાં જે કેસીસ રેફર થઈને આવતા હતા અને ડેથ થતા હતા, એ કેવા કેસીસ છે એનું બહુ સારું એનાલિસિસ કરીને આપ્યું હતું. બેઝડ ઓન that is the how we can contribute as a continue of the care. કે પેશન્ટ મારી પાસે આવ્યો, મેડિકલી એ કમ્પ્લેન હતી, પણ એને આવતા એટલે પહેલાની આખી જે સિચ્યુએશન હતી, ક્યાંથી શું હતું, અને એ નીચલા નેટવર્કની સાથે કયા કયા બાબતો હતી જે અલ્ટિમેટલી જે પેશન્ટને તમારે ત્યાં આપણે હોસ્પિટલને આવવામાં વખતે એના આઉટકમને અસર કરી હતી. તો આઈ થિંક ધેટ એનાલિસિસ બહુ સારા કરવામાં આવ્યા હતા. સિમિલરલી વી કેન હેવ ધ એનાલિસિસ ઓર ઇવન નોટ એનાલિસિસ, તો ઘણીવાર બેઝિક એક્સપિરિયન્સના આધારે વી કેન સે ધેટ કે આ કોમ્યુનિટીમાંથી, આ એરિયાઝમાંથી કેસીસ વધારે છે, આ પ્રકારના કેસીસ વધારે આવે છે. સો ધેટ કેન બી લાઈક ફોર એક્ઝામ્પલ ડેન્ગ્યુ કેસીસ રિપોર્ટ થયો છે તો કે ડેન્ગ્યુ આ એરિયામાંથી વધી ગયા છે. ધેટ ઇન્ફોર્મેશન ઇફ યુ વિલ બી પાસિંગ ઓન, ધેટ ઇન્ફોર્મેશન વિલ બી યુઝફુલ ફોર ધી increasing the surveillance and early identification of outbreak અને ઇમ્પ્રુવમેન્ટ કરી શકે છે. ઓફકોર્સ એઝ અ પાર્ટ ઓફ સર્વિસ પ્રોવાઇડર્સ તો છે ટર્સરી કેરની અંદરમાં જે આપણો મેઇન જોબ છે, જે મેટરનલ ડેથની અંદર જે ઇન્ફેન્ટ મોર્ટાલિટીની અંદરમાં by extending good maternal obstetric services by good quality and high class neonatal care units ઉભા કરીને કરી શકતા હોઈએ છીએ. Similarly all NCDs ની અંદરમાં, TB ની અંદરમાં how we can contribute to the TB, એટલે બધાની અંદરમાં પણ એઝ અવર રોલ સર્વિસ પ્રોવાઇડર તરીકે થઈ શકે છે. બટ ધ ઓનલી થિંગ ઇઝ ધેટ ધીસ સર્વિસ વી આર extending and providing, but we are providing in isolation as a closed institute. The only thing is that as when we are as a role as a TAAHO, when we are seeing in the TAAHO, we are seeing our role. So it has to be open institute તરીકે આપણી આજુબાજુની જે ગવર્મેન્ટની બીજી ઇન્સ્ટિટ્યૂટ્સ છે એની સાથે આપણું લિંકેજીસ કરીને કનેક્શન ડેવલપ કરી અને આપણે સર્વિસ પ્રોવાઈડર કરી શકીએ છીએ. અને એના માટે 2 ઇમ્પોર્ટન્ટ એક્ટિવિટીઝ છે. એ છે કે રેફરલ અને બેકવર્ડ રેફરલ, ફોરવર્ડ એન્ડ બેકવર્ડ રેફરલ. બેકવર્ડ નથી પણ બેકવર્ડ રેફરલ છે. ફોરવર્ડ એન્ડ બેકવર્ડ રેફરલ એટલે આપણે ત્યાંથી જે આવતા હોય પેશન્ટ એને રેફરલની મિકેનિઝમ પ્રોપર કેવી ક્યાંથી છે, એ ગુડ રેફરલ સાથે આપણે હેલ્થ આઉટકમ્સ ઇમ્પ્રુવ કરી શકીએ છીએ. ગુડ રેફરલના આધારે આપણે અથવા રેફરલના આધારે આપણે કઈ જગ્યાએ ઇસ્યુઝ છે જ્યાંથી રેફરલ વધારે થાય છે એ રેફરલ એનાલિસિસ અને એની સિસ્ટમ સારી કરીએ. આપણે ક્યાંક મોકલીએ ત્યાં અથવા આપણે ત્યાંથી આવતા હોય ત્યાં. એસએનસી ની અંદરમાં ફોર એક્ઝામ્પલ પેશન્ટ બાળક સારું થઈ ગયું અથવા ન્યુનેટર માલન્યુટ્રિશ બાળક સારું થઈ ગયું હોય પણ એનું બેકવર્ડ રેફરલ થઈને એ બાળક પછી કન્ટિન્યુ જીવતું રહ્યું છે, બાળકની હેલ્થ સારી રહી છે, એ પણ અગત્યની છે. એ રીતે ઓબ્સ્ટેટિક કેરની અંદરમાં કરીએ કે પેશન્ટ જે આવ્યો છે ઓબ્સ્ટેટિક કેરની અંદરમાં, એ પેશન્ટ જ્યારે પીપી જે એના પોસ્ટપાર્ટમ પીરિયડમાં છે એની અંદર કોઈ કોમ્પ્લિકેશન કોમ્યુનિટી લેવલ પર થયું નથી, તો એ કઈ રીતે લિંકેજીસ, હાઉ વી કેન હેન્ડ ઓવર ધી પેશન્ટ. જે આપણે ત્યાં બાળક આવ્યો છે, ઓબ્સ્ટેટિક કેર આવ્યો છે, એનસીડી ના કેસીસ આવ્યા છે, વી હેન્ડ ઓવર ટુ ધી સર્વિસ પ્રોવાઇડર્સ એટ ધી સેકન્ડરી ઓર ટર્સરી કેર લેવલ, પ્રાઇમરી કેર લેવલ. એ એક આખી સિસ્ટમ એ પણ આપણે થઈ શકે છે. અને એના માટે સૌથી ઇમ્પોર્ટન્ટ છે ઇન્ફોર્મેશન શેરિંગ. જે મેં આગળ વાત કરી ને, જે ઇન્ફોર્મેશન શેરિંગની અંદરમાં જેમ 2 મેડિકલ કોલેજીસમાંથી સ્ટેટ લેવલ પર પ્રેઝન્ટેશન કરવામાં આવ્યા હતા અને જે શેર કરવામાં પણ આવ્યા છે એમઈ ગ્રુપની અંદરમાં, તો એ ખરેખર એ સર્વિસ, એ ઇન્ફોર્મેશન શેરિંગ જ્યારે આપલે થાય તો ધીસ ઇન્ફોર્મેશન, અને કહે છે ને કે ધ વર્લ્ડ વિલ બી રૂલ્ડ બાય ધ પીપલ હુ આર હેવિંગ ધ ઇન્ફોર્મેશન. એટલે સાચી અને યોગ્ય ઇન્ફોર્મેશન યોગ્ય વ્યક્તિની હાથમાં જાય તો ડેફિનેટલી એ સોના જેવું કામ કરતું હોય છે. એટલે એ ઇન્ફોર્મેશન જે ઇમ્યુનાઇઝ, મારો બાળક ક્યાંથી આવે છે તો બાળકની જે હેલ્થ સ્ટેટસ છે, એની ઇમ્યુનાઇઝેશન સ્ટેટસ છે, મધરનું ઇમ્યુનાઇઝેશન સ્ટેટસ છે, એનસીડી કેસીસના છે, ફોર એક્ઝામ્પલ ડેન્ગ્યુના કેસીસ, ડિપ્થેરિયાના કેસીસ રિપોર્ટ થયા છે, તો એ ડિપ્થેરિયાના કેસીસનું સર્વેલન્સ જે આઈડીએસપીની અંદર આપણી સિસ્ટમ કામ કરતી હોય છે એ રીતે, તો એ સિસ્ટમ પ્રમાણે આપણે લેબોરેટરીના કેસીસના રિપોર્ટિંગ કરતા હોય છે, ક્લિનિકલ કેસીસના રિપોર્ટ કરતા હોય. એ ઇન્ફોર્મેશન, ધીસ ઇઝ ધ વન સિમ્પલ એક એસ્ટાબ્લિશ સિસ્ટમ. એના સિવાયની પણ સિસ્ટમ આપણે તાહોના ભાગરૂપે એસ્ટાબ્લિશ કરી શકીએ એકબીજાની સાથે. અને ઇન્ફોર્મેશન શેરિંગ કરવામાં આવે તો જે ટર્સરી કેરના અનુભવના આધારે પ્રાઇમરી એન્ડ સેકન્ડરી, પર્ટિક્યુલર પ્રાઇમરીમાં પ્રિવેન્ટિવ પ્રોમોટિવ કેર માટે પણ બહુ સારું આપણે એની અંદર કન્ટ્રીબ્યુશન, એટલે વી કેન પ્લે એઝ અ રોલ એઝ અ પાર્ટ ઓફ ધ ટીમ વિચ ઇઝ basically with the aim, which is basically part of the system which is aiming of the continuum of the care. So with this all, I thank you all for your patient hearing, and thanking Dr. Lipi Shukla and others for providing me an opportunity to share my ideas. Thank you very much.
Thank you very much, sir. It was a really wonderful, informative session, and gave the overall idea of not only the Niti Aayog Health Index, but we have also included other aspects of Gujarat and Indian data, the key targets which are set under TAAHO. Present situation is also shared by you. Thank you very much, sir. Now we will move on to next session. Before that, I would like to remind you all that the registration link is shared in chat box. Those who have not registered themselves, please get yourself registered by following that link. There are very few fields needs to be filled up. So by now, I think overall idea of what the targeted approach to accelerate health outcome is covered by 2 speakers. There is our director, sir, and executive director of SHSRC. Let us look at different targets under TAAHO. I would request to share my PowerPoint presentation. Let me introduce myself first. This is Dr. Lipi Shukla. I am Associate Professor in charge and Medical Lecturer at State Institute of Health and Family Welfare, Vadodara. Targeted approach to accelerate health outcome is a concept. Rather, we are doing all the things that are discussed in this targeted approach. There is nothing new, but we need to focus upon some areas, some targets, and to achieve that target, we need to focus some interventions. We need to focus on the interventions and we need to implement it better. I would like to inform that targeted approach to
Lippy Ben, sorry to interrupt. Your audio is not connecting. હેલો લિપિબેન તમારો ઓડિયો કનેક્ટેડ નથી.
not possible. Deaths are inevitable, but what we can do is we can avoid preventable causes of death. We can address or we can work for preventable causes of death. So our target should be realistic and our objectives should be smart, as we all know. And that is why presently we want to achieve 50% reduction of maternal death by the end of financial year. And we are very near to the end of the financial year, but this it will be an ongoing process. In next year also, we will be implementing this TAAHO in all the districts. So, zero maternal death is a concept, and the realistic target is 50% reduction wherever we are. If we are having 70 deaths of mothers per 1 lakh live birth, then we would like to reach up to 35. So the target for maternal death is 50% reduction wherever you are, wherever we are, and the another target is 50% reduction in infant death. In case of full immunization, the target is 100% reduction. And in the treatment of severe anemic mothers, severe anemia during pregnancy, all the mothers should be put on treatment and their hemoglobin level needs to be raised before they come for delivery. Other 4 targets are also there. I will be focusing on initial 4 that I have highlighted in red color. So let us go to the first target. 50% reduction in maternal death. For all the targets to be achieved at state level or at district level, there are some focus areas decided because we are providing so many services. In maternal health, we are providing starting from early registration, antenatal care, 4 visits, and tetanus toxoid injection, iron folic acid tablets, calcium, everything. Institutional deliveries we are enforcing upon. Everything we are doing, but what things are there that will make an impact on your indicator. The most important things which are there, they are identified, and these are identified as focus areas to accelerate health outcome. Focus areas to work upon by all the health staff. Some of these focus areas are largely related to community health services, not to facility based services, but still I have kept it because it is the part of a TAAHO program. And as we have already discussed, community health cannot be separated entirely from the facility based services, and this reduction in all these deaths, maternal death, infant death, cannot be achieved without the partnership of district hospital and medical colleges. So our first focus area is early registration, and that should be 100%. All the mothers should be registered early within 84 days of gestation. That is in first trimester. We need to register all our mothers. Yes, at district hospital level, the registration for the registration, you are not going to go in community, but our community health workers registers their ANC of their area, and they follow the ANC, and if needed, they refer these antenatal mothers to secondary or tertiary level facilities, and the role of district hospital or medical college attached hospital comes there, and whatever referral services they need to provide at their hospital. Then another focus area is timely identification of high risk antenatal mother. If the mother is having any kind of danger signs, our community health workers needs to identify, and even if they are not registered or somehow they are missed by our community health workers, then and they are taking services at district hospital or any private hospital, the screening for danger signs should happen at all levels, at all antenatal clinics. And another last and not the least focus area is reduction in maternal death. So these are identified three focus area, because if mother will be registered earlier, they can be followed. We can follow once the register will happen. Otherwise, if the mother is not registering for 4 months, 5 months, and she will miss initial services from the service provider, and it will affect over the long run to the health of the mother. State is monitoring some indicators for maternal death. Identified decided indicators that are in line with Niti Aayog Health Index are maternal death itself, then proportion of high risk mothers examined by specialists, and early antenatal care rate, early ANC registration rate. These three important indicators are monitored every time. In hospitals also, if you are having, you will not be having denominator of entire population that a medical college hospital will be catering, but you can use your hospital based data also, and you can derive all your indicators out of your hospital data. Early ANC rate of total ANC registered, that can also be reflected from your hospital data. So it is this description is given to all the health officers, and how these indicators will be monitored. Numerator and denominator, I think I will not go into greater detail of it, but for the maternal death, number of maternal death within from conception to 42 days postpartum, out of 1 lakh live birth is measured. High risk mothers examined by specialist. Here it is mentioned that examined by specialist. This indicator is also a community based indicator, but in medical colleges we are already having gynecologists. They all are specialists only, but in field, in primary health center and in community health center, there is a program known as Pradhan Mantri Surakshit Matritva Abhiyan (PMSMA), under which a gynecologist is empaneled at primary health center and community health center, and on every ninth date of every month, the ANCs or high-risk ANCs are referred to that gynecologist. So all the ANCs needs to be once given checkup by gynecologist through this PMSMA implementation, and high-risk mother, for this high-risk mother, all the medical officers are also supposed to visit this high-risk mother and treat accordingly and follow the treatment given by gynecologist at PHC level. Early ANC rate is the number of total pregnant women registered within first trimester out of total number of registration. There are some in this TAAHO module. We have provided guidance over the roles and responsibility of all the health staff. That is also classified into community-based services and facility-based services. In community-based services, the role and responsibility of all the staff of primary health center, starting from ASHA to medical officer, is given, and it is very clearly written. I have put here only the facility-based services staff, and that is also customized to medical colleges. In the facility services at community health center, we implement some programs that are also implemented at medical colleges, and we have identified some focus areas to do there also. There is one thing called birth micro plan. Whenever a mother is registered by a female health worker or ASHA, on the same date of registration, a birth micro plan needs to be prepared. The implementation is still not uniform at each and every level, but birth micro plan concept is very good if it is implemented very nicely. In that, the ANC is given guidance upon the planning of her institutional delivery. After the and this birth micro plan is reinforced in third trimester, and in this the transportation, the hospital is decided, who will accompany the mother during pregnancy, during delivery, that is also decided, that we call it as Mamta Sakhi, is decided. If the mother is residing somewhere in hard to reach area, in this birth micro plan we also give her the date to come at Mamta Ghar, that is available at district hospital or at CHC also. So implementation and compliance with birth micro plan is very important at medical college attached hospital level also. Then comes effective implementation and use of simplified partograph. Simplified partograph is a very good tool to be used, and that can be used by staff nurses. And this using partograph is also done by female health workers who are posted at functional delivery point. And another thing is safe checklist. There are 4 checklists under safe birth checklist that also needs to be used by staff nurses, those who are working in Navjivan Kaksh, or what we call it in routinely labor room, but we are supposed to call it Navjivan Kaksh or birthing room. So implementation of both these tools will really help in reduction of maternal mortality by early identification of non-progress of labor or prolonged labor. Then we have Janani Sishu Suraksha Karyakram that needs to be implemented in all government facilities. Cashless services needs to be provided in all maternal and newborn and child infant care services. This because the private medical colleges has also joined. I'm explaining something that may not be implemented in private setup. This Janani Sishu Suraksha Karyakram is having entitlement, free entitlement for all the ANC free institutional delivery and free transportation, and some, if required, blood transfusion can also be given free of cost to all the mothers. No, mothers should not be given any charges for any services up to the age of 1 year of infancy. Then comes appropriate risk identification and timely appropriate consultation with the specialist by staff nurse. All these activities needs to be those for the staff nurse who are working in Navjivan Kaksh. Resident doctors also, those who are working, those who are pursuing their gynecology MD, they are also supposed to do all these things and needs to implement this better, all these national health program at their department and labor rooms. All these specialist gynecologists, faculty of Department of Gynecology, their role is to manage high risk mother in antenatal period and during delivery. Whatever risk identification is done by resident doctor and staff nurses, they need to just respond them promptly, and they need to manage to avoid maternal death. Superintendent at any hospital is expected to do the supportive supervision of all hospital staff and effective managerial support. Let us move to the next target, that is 50% reduction in infant death. The focus area for infant death are first and foremost is each and every infant death is to be reported. Sometimes it happens in field also, the infant death not reported within 24 hours and not reported at all. That may also happen. But in hospitals, as the admissions occur, all the records are maintained, the infant death are reported, but the reporting should be within 24 hours. Identification and appropriate referral and ensure treatment compliance of all the high-risk neonates. As we all know, the golden 1 minute, first day of life, first 24 hours of life, and first week and first month of neonate is very important, and it is very crucial. And the maximum number of infant death are occurring during this period only. That is why high-risk neonates needs to be identified and managed appropriately. In TAAHO, breastfeeding assessment is also given importance, and kangaroo mother care is also extended not only to the low birth weight baby but to all the newborns, because it is having so many advantages. I think we will not be able to go into greater detail, but these are the some focus areas identified under TAAHO. Then comes the screening of 4Ds. 4Ds are defect, disease, deficiency, and developmental delays. These mainly in community health services. This 4D screening is done by Rashtriya Bal Swasthya Karyakram, that we call it as RBSK. And these, if they are identified, the main role of tertiary care hospital comes over here. This birth defect, any disease, deficiency, or any kind of developmental delays, if identified, the help of pediatricians are expected over here, and appropriate referral of newborn with suspected 4Ds is another focus area under TAAHO. The important indicators measured for the monitoring of TAAHO program is infant death, home-based newborn care visit, and the newborn screening for 4Ds. Newborn screening for 4D is happening as a RBSK program part in community, but that can also be implemented at facility-based services at your hospital also. Home-based newborn care visit is entirely community-based program. Whatever institutional delivery is happening at your hospitals or in your labor room, these neonates are being followed by ASHA and ANM in community on a scheduled date after birth. That is on 0 day or day 1. Then comes on day 3, 7. day 14, 21, 28, and last day of postnatal period, that is day 42. These HbNc visits are also continued later on by the concept of HbYc visits. HbYc is home-based care of young child. HbYc visits are also carried out every 3 months after 42 days, every 3 months till 18 months of age. These are the important indicators which are measured. This can also be measured at facility level, and of your facility you can derive all these indicators, and you can monitor over the period of time monthly by preparing a graph or table. You can monitor your own data as compared to last year, whether the infant deaths are increased or decreased. The role of facility-based service providers in child health is again staff nurse, resident pediatricians are their role comes over here, and superintendent can help in managerial support. Let us discuss the role of staff nurse is promotion of kangaroo mother care, promotion of breast crawl. We are talking of delivery on abdomen since years together, but still there are facilities where babies are being taken in tray. But now the time has come to start this delivery concept of delivery on abdomen, so that we can extend it to the we can also start breast crawl. Impart the benefit of JSSK, that is all free services after childbirth till 1 year of age. Even free transportation in Khilkhilat and 108 is also implemented. Navjat Shisu Suraksha Karyakram that we have already discussed, all the essential newborn care should be given to all the neonate, that can be given by staff nurse itself, and that can be given by medical officer or pediatrician. Essential newborn care, that is the care of skin, care of eye, care of cord, everything, immediate care after childbirth should be reinforced. Every initiation, early initiation of breastfeeding and exclusive breastfeeding is also the most cost effective intervention that we are practicing, and we intend our patients or our beneficiaries to practice since years together. Identification of danger signs in newborn by staff nurses and timely referral to a resident doctor, or from a resident doctor to a consultant. Timely referral is very important. All these same thing can also be done by the resident doctor. Pediatricians needs to manage all the high risk neonates and children, those who are identified of having danger signs, and all 4Ds, screened and suspected children. The target of full immunization coverage is 100% coverage, because there we cannot compromise, or we cannot have a target of having 50% coverage or 65-70%. All the children needs to be, they are to be immunized fully. That is their basic right. We can understand, because leaving one children unprotected, the population or 1% we leave it, it will be number of children would be very high of unprotected children. So the full immunization coverage target is 100%. There is no compromise over there. And during COVID scenario, so many of our pediatrician friends have shown their concern. Those who are working at district hospital, but they are not having the mechanism of following their own patients, their own clients coming for immunization at a district hospital or medical college attached hospital. They shown their worry that our regularly coming patients are not coming for immunization during this COVID scenario, and after if we are working so much for COVID, we are doing so many activities for COVID, but we will be losing our basic indicators, our basic infectious disease protection, whatever we are giving to our children, that was the major concern by so many pediatricians working at. So, with the help of this TAAHO program and the continuum of care approach, we have the community health worker, those who are following these children, these mothers at their doorstep, at their home. If we have some mechanism of coordination from district hospital to their catchment areas, whatever the CHCs they cover, whatever primary health center or district they cover, they need to have some contact number of the key person or officers from the field, and they just need to exchange the information of left out or dropouts from their facility based services, so that we can manage, we can start implementing this continuum of care approach better, and back referral of these children that is practiced in this management of SAM program, that needs to be implemented everywhere. The back referral to the field level services by just providing information of discharges or left out or dropout to concerned primary health center or concerned community health center will really help in providing better services and providing better coverage in all these services. So, our focus area in this full immunization coverage is to impart national immunization schedule perfectly, to perform safe injection practices, presence of service providers and beneficiaries as per microplan during entire Mamta Day. I do not know about the medical college attached hospital. We have studied over there, but we call it immunization clinic over there or antenatal clinic over there. Why can't we call it Mamta Day at district hospital also? The Mamta Day is implemented in field and in primary health center, even in community health center since years together. The same concept or the same nomenclature that can also be utilized at medical college level hospital to identify this immunization clinic or ANC clinic, and to deliver 4 key messages after giving immunization is one of the important focus area. 4 key messages includes, the first message is which vaccination, which immunization is given to the child. Then comes the which disease against which it is protecting us, protecting the then giving the due date for the next dose when mother or child needs to be brought back to hospital, the follow-up date needs to be given. And fourth key message is keeping the Mamta card or immunization card safe and bringing it every time with the child. These 4 key messages needs to be reinforced after every immunization. Ideally, it should be given before giving injection, because after giving injection, the mother and child would be restless because child will be crying. So nobody will listen to service provider's instructions. So all this instruction needs to be given before giving vaccination. The indicators measured for immunization coverage is full immunization coverage itself, which includes all the vaccines less than to be given according to national immunization schedule in less than 1 year age group. In this, rotavirus vaccine only is not included. Number of Mamta sessions organized, that is again a community based indicator, but that can also be monitored at your facility. How many immunization day you have planned and how many out of that you could organize. Okay. The role of medical college or hospital is, we have already discussed. Tracking of dropout can be strengthened by giving the due list of your children taking immunization at your clinics to the community health worker. We just need to establish a linkage, what theoretically we are talking about since years together. The last target that I am supposed to talk about is 100% treatment of severe anemic mother or severe anemia in pregnancy. Here, all the female health worker in the community needs to be do hemoglobin test of all the pregnant women. That is one first focus area. In tertiary care hospital, that is not an issue because you are having separate laboratory. But at sub-center level, all the ANCs, those who are taking ANCs at outreach Mamta session, their hemoglobin estimation is an issue. They are not measuring it every time, but once during throughout the 9 months they are measuring. That is not right, and every time FIW needs to measure this hemoglobin level at least 3 times in 9 months. Classification of anemia, right classification of anemia is also an important indicator or focus area for because sometimes field workers do not identify a mother is having anemia. They do not perceive it to be anemic. That is also dangerous for anemic mother. And treatment and ensure compliance of medical treatment. We all know as giving IFA tablet is very easy, but maintaining compliance to IFA tablets is very difficult. That requires so much of counseling and nutritional support also. So here we need to ensure compliance to medical treatment or injectable, oral, whatever that may be, so that we can reduce the blood transfusion rate to the anemic mother. In this severe anemia, the indicators measured are anemia testing in pregnancy and severe anemia treatment rate. Number of mothers received treatment of anemia and they have now normal severe anemic. That indicators are being measured. The role of medical college, we have already discussed the maternal health aspect previously in first indicator itself, but here the management of severe anemic mother can be done at tertiary care hospital and whenever the blood transfusion is required. But we need to try altogether that any mother should not go into severe anemia by frequent follow-up and by ensuring compliance to IFA tablet. Here iron sucrose is also one of the important intervention that is used nowadays very frequently. This slide you have already seen before. Again and again some slides are repeated, but it's important as far as TAAHO is concerned, and in public health staff trainings these things are reinforced so many times that if you do work, do report it. Otherwise, there is no point in doing. If you have not reported, at least in government setup, if you have not reported your work, it means that you have not done work, even if you have done it very nicely. But in tertiary care hospital, this data reporting and maintaining registers are also a difficult task because of having high case load. So, desired is true data reporting of truly done quality, good quality work. Because if the work is done, quality assured work is done, it will always ensure safety. So, thank you everyone for listening patiently. Now, I will request Dr. Parag Chavda to take over this session and guide this audience for the next 4 indicators of TAAHO. Out of total 8, Dr. Parag Chavda is assistant professor from Department of PSM, GMARS Medical College, Gotri. Over to you, sir.
Thank you, Lipiben. So I will start from the indicator number 5 on nutrition. Lipiben, the earlier Madak sir, Kadri sir, and Lipiben have talked in detail about the concept of TAAHO. and I'll be talking about the rest 4 indicators a little quickly. And then since we understand that the audience for this program is medical college faculty, uh, we have also kept some photographs of some of the facilities and some of the services which are happening in the periphery, about which the medical college faculty as usual or in routine, it might be new to them. So to make the medical college faculty aware about these aspects, we have also included some photographs at the end, which would probably help us understand how the peripheral health system is also functioning, about which Kadri sir was mentioning earlier. So I'll start with the indicators first very quickly. So if we talk at the nutrition, unfortunately, okay, I hope my voice is audible now.
So your voice is audible. You just need to speak little louder.
Yeah, yes. The fifth indicator is with regard to nutrition, and the indicator which is selected in TAAHO is severely acute malnourished children, severe acute malnourished child. So we are expecting a 50% reduction in malnutrition in that way. If we see in Gujarat, Gujarat is considered to be a developed state, and we are economically very prosperous. But at the same time, we have probably heard this story multiple times that when we look at our malnutrition indicators, we are not doing as great as we are expected to be doing. If we look at the latest NFHS 5 findings on undernourishment in Gujarat, they are also they continue to be alarming. So children with severe acute malnutrition, it goes to the tune of almost 10% of the all children in under 5. So which is quite huge. Children suffering from severe form of malnutrition, and that too almost 10% of the children, which is one out of every 10 children. So what's happening in the community, in TAAHO community program, is that we want to detect all those children and put them on treatment and continue to have them a nourished diet. So the focus areas then in for the field mainly are to screen and identify all those SAM children and ensure treatment compliance. And then the treatment for SAM is usually divided into two portions. One is, it could be community based or it could be facility based. The facility based is usually when the severe acute malnutrition is also associated with some complications, wherein Kadri sir mentioned earlier that we have child malnutrition treatment centers at community health centers. So at there the treatment is ensured and then the child goes back to the community, or we have nutritional rehabilitation centers at district hospitals and medical colleges. So these two are the places where facility based care of severe malnourished child are happening. And there is also community based care which happens mainly at the village level through the Anganwadi system. So these are some of the indicators that we are using in community. So proportion of SAM children identified and treated. Second is a successful discharge rate from NRC and CMTC. And the third one being successful discharge from the program, which means that whether the child gains weight as per the criteria at the end of their stay at CMTC and NRC. So those are the indicators which are being monitored. And medical college hospitals, most of them have NRCs, and these are the indicators expected to be monitored there also. This is for those of us who are not aware. This is, I've just shown one photograph of a child malnutrition treatment center. So this would usually be within the premises of a community health center, usually located at taluka headquarters. So so many talukas are now having these. It's usually a 10-bedded facility where the medical expertise or medical officer comes from within among the medical officers available at CHCs. And then there is some additional manpower also available in the form of a nutritionist, a cook, and a separate staff nurse dedicated for this purpose. So this is also available at the field, followed by nutritional rehabilitation centers, which is a little bigger setup and a little bit more advanced setup, which is available at district hospitals and medical colleges, which many medical colleges would be aware about. that might be between 10 beds to 20 beds. Now, if we move on to discussing what's the role of medical college hospital, first, as we can understand, is that being at the highest level of management for all illnesses pertaining to, let's say, children. First is facility-based care of a SAM child at nutritional rehabilitation center is the natural expectation. Another important thing when it comes to SAM children or children with malnutrition being managed at medical colleges is the back referral mechanism. Kadri sir and Lipi Ben have also been mentioning this, and this is really something which on which we need to work upon further. How do we ensure that once a child goes back from a nutritional rehabilitation center back to the community, the child does not end up being malnourished once again? Once the child gains weight and gets discharged, how do we sustain that? A lot of I have purposefully mentioned the word operational research there because what we understand is that many a times our medical college departments are engaged in research and research which is hospital based or dominated or focused upon clinical care. What we would need in future is operational research, which means that how do we improve the existing practices, how do we improve the existing systems, and how do we translate whatever we know into practice. It's really very difficult to understand that in spite of so much of our economic progress, a large proportion of our children go undernourished. And what can we do about them so that we can maintain the nourishment status? So operational research in that area is also needed. We move to the next indicator, which is with regard to tuberculosis and HIV/AIDS. The target being 100% screening for tuberculosis and HIV, and then the treatment as well. So the focus areas are to identify and refer presumptive cases of tuberculosis, collect and transport sputum sample, ensure timely follow-up and treatment compliance of TB cases, and the last one is the opportunistic screening of HIV and TB and of TB and HIV both ways. So these are some of the indicators that have been used in TAAHO. Tuberculosis case notification rate, public and private institutions as against the targeted cases, treatment success rate of all new TB cases, opportunistic screening rate, both ways for TB cases among HIV and for HIV cases among TB. And the sources for this data have also been mentioned. NICSHRE has been in implementation since a couple of years now, and it had initial some hiccups, but now it's being streamlined. What would be the role of a medical college is once again here also the referral and back referral system are something which needs to be strengthened. Operational research, fortunately, tuberculosis program and HIV programs are providing funds also for operational research since many years now in the area of tuberculosis. So how do we improve our health system responses around tuberculosis care is something where more focus needs to go. The seventh indicator is vector-borne diseases, and target is malaria elimination as per the malaria-free Gujarat. Focus area is effective implementation of the drug policy, which is for the treatment of malaria, and for the prevention aspect to conduct fever surveillance in the periphery. So some of the indicators are parasitic incidence, treatment rate, so number of newly diagnosed malaria cases put on treatment within 48 hours. So this we mainly use at the peripheral level, where we want that all people, all the fever cases for whom the test has been done in the form of either blood slide or rapid diagnostic test, they are put on treatment within that stipulated time. And the other indicator being blood examination rate, which is the population percentage of population who is screened for malaria parasite. Fortunately, in Gujarat, this particular indicator is reasonably good. We have been able to achieve almost 15% to 20% annual blood examination rate across our populations. What could be the role of medical college in malaria program or vector-borne diseases is the first that comes naturally to our mind is management of complicated cases of vector-borne diseases. Correct report, IDSP reporting of the cases is something which can improve upon, and linkage with the health system for follow-up of the cases. So once the patient gets discharged, in the peripheral health system, there is a beautiful system of ensuring that the radical treatment for malaria is provided to the patient, as well as repeat follow-up smears to ensure cure are also happening. So if the patient gets discharged from a medical college, the medical college consultant can also ensure and have back referral mechanism to ensure that when the patient goes back to home, the peripheral health system, the PHC teams, are able to take follow-up smears of these patients as well. About non-communicable disease, this is an emerging area for all of us, and when in the earlier presentation, when Kadri sir showed that the prevalence of hypertension goes to the tune of 5% and 10% of the population among men and women, those proportions we might feel that it's low, but when it comes to absolute numbers, they are staggering numbers. So we understand that tertiary care hospitals, medical college hospitals, or district hospitals alone, when it's in so many huge numbers, will not be able to reach out to them, and hence the treatment of non-communicable diseases will have to make it available through the peripheral centers also, which means the primary health centers, which means the community health centers, and maybe sub centers as well. So what's happening in this area is we are targeting two focus areas. The target is NCD screening as per the PIP target, and the focus area is to identify and correct modifiable risk factors of NCDs. So what's happening in the peripheral health centers, health facilities, or in the villages through ASHAs is the screening of the risk factors of non-communicable diseases among all the adult population above 30 years of an age. So that's what we are targeting at. We in the public health system do not wait for the time that the person develops hypertension or develops diabetes and then we treat hypertension and diabetes. That would be too late and too costly for a health system to work. And second aspect is identification, appropriate referral, treatment, compliance, and follow-up of non-communicable diseases. This also I mentioned earlier that the numbers are so huge that it's just not possible that only the hospital or health facilities are providing treatment for the hypertension and diabetes. So this treatment also needs to go a little deep, lower down in the hierarchy of the health system. And now we are saying that this dispensing of the medicines, regular medicines, will be possible through health and wellness centers as well. So the indicators is the number of people 30 years and above who are screened for non-communicable diseases. I've just mentioned a few screenshots of the checklist that ASHA is using in the field level. So we popularly refer to it as CBAC form. It is community-based assessment checklist to be used by ASHA for all people above 30 years of an age every year. So since it's ASHA, the expected skills are only interview skills that we expect. We do not expect her to be doing examination of the person. So she interviews and identifies the risk factors such as age, alcohol, waist circumference, obesity, physical activity, and so on. And there is a scoring system. So she scores, and then a person having above 4 score indicates that the person at high risk, and the person is referred to further at the health and wellness center. So that was it. Other part of the CBAC, which is usually filled by ASHA, has some questions which focus on the different types of cancers also. And then apart from that, there is also the new concept which has come in the last couple of years is the sub centers, where otherwise only male and female health workers, which are equivalent to staff nurse in a hospital, were available, and they were at some days of the week they were available at the sub center building for consultation and running clinics, and other times they were going into the field for field visits. Now uh, almost half of them, as Kadri sir showed the numbers, almost half of our sub centers have been converted to health and wellness centers, where we have placed a community health officer who is a link between the medical officer MBBS available at PHC and the ASHA available at the village level. So that person is designated as an officer, usually comes many of these CHO have been trained by us at medical college levels when we were running the certificate course in community health, the 6 months course. And many medical colleges and many departments have also contributed their expertise in developing this particular new cadre of community health officers. So these community health officers are now managing the upgraded sub centers which are labeled as health and wellness centers. and their job profile, which is a new cadre, is also running OPDs at the centers as well as some of the field visits. So I'm just showing some photographs where the one of the community health officer is doing screening, blood pressure monitoring for within the health and wellness center as well as during the field visits. So this is also, I wanted to show that this is also happening. When we say the numbers are so huge that not only the health facilities or tertiary or secondary care centers would provide care, it needs to go to the village level as well. What could be the role of medical college for NCDs is something that we can probably still improve upon is screening for non-communicable disease among all OPD attendees. This might be happening in some of our departments, but for the rest of the departments also this can probably improve upon. Treatment of referred cases of NCDs referred from the PHCs is probably happening. Training of peripheral doctors or staff is what SIHW is actively seeking help from the medical college departments on. So for example, the community health officers and the field staff, now we are expecting that they'll be doing, ASHA will be only interviewing, but the health staff would be doing oral examination for possible detection of cancer at an earlier age. Visual inspection of cervix is what is expected at the field level. Early breast examination of the women is also expected. So when we are training our health manpower on these aspects, the expertise from the medical college departments can also help in training the staff members. And we say, as we mentioned earlier, that the medical college, the medical officers at PHC also now need to understand the NCD management. Gone are the days when we felt that only the specialists would be treating hypertension and diabetes. Now we want and we expect that our medical officers should also be able to treat diabetes and hypertension. So many medical officers have many queries and questions. They do not feel themselves to be very highly competent in treating these diseases, and so we are coming up with training programs for medical officers on NCD management, and we want help from the medical college experts in training medical officers in the NCD management. Another important aspect is not only with NCD but in general is that eSanjeevani has rolled out very nicely and is running. So many of almost most of the consultants are available at some fixed duration of time per week in eSanjeevani. So what many of the consultants would have observed would be that in eSanjeevani even the patient can come and have direct consultation district hospital or medical college hospital, but sometimes you will see medical officers and community health officer seeking consultation that I encountered so and so patient and I had some trouble in diagnosing or in some trouble in managing the patient and I have this query, so please solve my query. So just a request from this side is that if you can handhold and mentor the peripheral level doctors and community health officers also through eSanjeevani and telemedicine, that would really help them. So this is one of the ways in which they are also seeking guidance and handholding. I intended to discuss the healthcare. So those were largely the indicators that I was supposed to be covering. Apart from that, I intended to discuss the healthcare system in Gujarat, but apparently Kadri sir has beautifully covered this very well in detail. So I'll just very quickly run through this. Our system is divided into three portions: primary level, where medical officers and community health officers are available. And I wanted to highlight this particular last line where health and wellness centers, we are talking about them. So we have 5 or 6 health and wellness centers available per PHC eventually, and we have community health officers, which is a new cadre within the health system, largely the focus being preventive and promotive. The other cadres we are usually aware about at primary health centers. We have MBBS available at community health center, which is a 30 bedded health facility or hospital at taluka level. District hospital is one hospital per district, and they could be having sub district hospitals also, and tertiary care hospitals. Now, an interesting way that the health system is moving ahead in future in Gujarat is that we have envisioned to convert most of our district hospitals into medical colleges. So that's also something that's coming up. There are other recent developments that are happening at a rapid pace in the health system at the peripheral level, about which the medical colleges might not be so much aware. So just wanted to enlist some of them. Quality assurance program, Lakshya, NQAS, Kayakalp have been going on in periphery since long time now, and they have helped improve the quality of a lot many operations in the health facilities. Mukhyamantri Nidan Yojana has an list of all the diagnostic facilities which were otherwise not available, now available at multitude levels, such as primary health center, sub-center also. Rashtriya Bal Swasthya Karyakram, I would wish to show you a photograph next. This Rashtriya Bal Swasthya Karyakram is a very beautiful program of school health, where there is a team of a male and female Ayush doctor with a staff nurse, with a laboratory technician and a pharmacist are available. A team of 5 people are available, and that team goes to school, does the school health checkup. And Lipiben earlier mentioned about the 4 Ds, and they are detecting deviations from health among the children. And the age group covered is 0 to almost 18 years of an age, which means they are also doing home visits for a detection of birth defects at an early age. So RBSK is also happening. So at medical colleges, sometimes we might end up seeing cases which are referred by the RBSK team. So, and sometimes medical college doctors, mainly pediatricians, are expected to be training the RBSK medical college teams. So at that time, it would be prudent that the cases that you see referred, maybe you can identify those gaps in the knowledge of RBSK teams or in the skills of RBSK teams, and in the subsequent trainings, if we can improve upon those particular gaps that we identify. These are some of the photographs I wish to show. This is a health and wellness sub-center in Narmada district. So branding has been done, and the new buildings have come up for many of the health and wellness centers also. In the urban areas also, the system is developing now, and urban primary health centers are developing in many of the district headquarters, taluka headquarters, and the peripheral urban centers also. So that's also developing. This I would like, if I could summarize the role of medical college in strengthening of the health system. The clinical care the clinical departments are already giving. What probably we need to focus upon further is how do we ensure continuity of care, the referral and back referral systems. Telemedicine is something which is coming up now, and probably we can utilize it to the fullest, to the greatest advantage. Education is core function of a medical college. And if the departments can identify the need-based training of peripheral doctors. So say for example, at our college, we did a quick survey among the peripheral doctors to know how much do they know about, let's say, treating common skin disorders. And we found out that a lot of medical officers at peripheral level need and express the need to learn skin management of skin disorders in greater detail. So that's what the need that we could find out. The similar needs would be there for the other departments also. So if the department could find out that need, and if we can collectively do something about it, probably that would be an extension of our efforts at education. On-site and telementoring of peripheral health facilities is something which can come up in future. At present, every medical college is given 10 health and wellness centers in urban and 10 health and wellness centers in rural areas for mentoring. The health facilities such as the community health centers also need a lot of hand holding. So if the experts from the medical college can visit these centers and improve upon giving clinical care at these places, probably that's what we are expecting in near future. And the last part is research. Two types of research that I would like to focus upon is research that is aligned on the national health priorities and which is operational in nature. So when I say operational, one of the important areas of an operational research happening in medical college would be, let's say, quality of care. We need to improve the quality of care of our hospital processes or of our hospital uh, operations also. So quality of care in itself is a very big area where probably the departments can focus little amount of their research into operational research as well. The last one being the translational research, which means that all the path-breaking research, the new knowledge that we get from research, how do we translate it into action? How do we ensure that all the knowledge that we get from research is available to the last person also? So those are the quick ideas on how medical colleges can strengthen the existing health system. That was all from my side. Thank you.
Thank you very much, Dr. Parag. It's already 5 o'clock, and we have covered all the 8 targets of targeted approach to accelerate health outcome. I hope this information will be helpful. And Dr. Kadri sir, as already sir has mentioned, the medical colleges to be information hub, the knowledge hub. The faculties from medical colleges can act as mentor, as trainers. They can help in monitoring of this implementation of national health program. Different departments can contribute in different ways. Apart from their basic area of work, that is service provision, tertiary care, and referral centers for all the primary and secondary level health centers. This way, medical colleges can help under TAAHO of the state and contribute in achieving these targets earlier by accelerating the services by the approach that we can implement. Dr. Parag sir has also mentioned very nicely the role of medical colleges in each area. I hope this information will be useful to everyone. And as the time is over, I think we will not be able to take the question answer right now because it's already 5 o'clock. And with all your kind permission, we are ending this orientation program on TAAHO. Those participants who are unable to attend today, they can join tomorrow. The same program will be given in this same platform, and this program will be streamed live on YouTube also on SIHFW channel. Those participants wants to see through YouTube, they can have a look at that. Thank you everyone for watching this webinar and participating. We are ending this online session. Thank you. Okay, so some requests are coming for sharing PowerPoint presentation that we will share to your email IDs in your registration. Thank you.